So the other important thing here is that in addition to practicing medicine, at some point you saw a lot of value in organized medicine, in your career and how you felt it was best to pursue your profession.
I did. I did. I was fortunate. I thank God every day. My parents, my father was an internist, my mother was a nurse. I was brought up in a medical family, even though I was not a pre-med student. All my undergraduate stuff was language, French, ancient Greek, Latin, that sort of thing. So I had to take some extra time to get pre-med stuff after college. But you know, that broad background and my family background helped me understand the importance of you know, being a good physician and the value of physicians to our society and nurses. I couldn't, you know, my sister was a nurse. I had 3 aunts who were nurses, an uncle who was a physician. So it was, you know, even though I as I said, I grew up not saying I'm going to be a physician.
Right.
In the end, I realized
you were immersed in
that's the way to go.
Right.
That's the way to go.
And you saw basically value in working with your colleagues to pursue the good of medicine.
Yes. Yes. I mean, having grown up in a family, I'm one of 7 kids. I knew we had to organize. So organized medicine, again, just was a natural as far as I'm concerned. And I'm sure this is true of many other past presidents. You know, I first became active in my own district medical society on the North Shore, you know, Essex South. I became a counselor and the president, and gradually, you know, learned the system of the medical society at the local district level, because really, again, as Tip O'Neill used to say, all politics is local. Is all medicine is local too. We have we have the academic think tanks but medicine is local. It's one-on-one with the patient. So I learned how organized medicine can help influence that at the district level, and then, you know, at the state level. And it was a great experience. My father was the president of Bristol South. I still remember giving, in those days, when you became a member of the medical society, you had to go to the district president, and they would check your credentials. You had to bring your diploma face to face with someone, and then there were what they called censors, where you had to answer questions. And my father, I had just finished my cardiology fellowship, and my father asked me to give him write one of the questions for him that he was going to ask.
Interesting, you know, sort of artifact from the history of the medical society, when in the 1780s up until the probably mid-1800s, it was the credentialing authority for practicing medicine. There was no state licensing board.
Absolutely. We were the ones who gave out the licenses to practice medicine.
Right.
And you know, I don't know if it was part of that, but it was after the Civil War, we became the first society to recommend a state Department of Public Health.
Right.
So Massachusetts, although there were county departments, you know, going back into the 1700s, but we were the first state to have a medical society say to the legislature there should be a state Department of Public Health.
Right.
You know?
So talk a little bit about your practice. When did you start in practice?
So I started in practice, let's see, I graduated from medical school in 1969 and did my internship and residency in New York. Interesting, the hospital in Manhattan, it was called St. Vincent's. About 10 years ago, it was a giant hospital, and it closed, and it was sold to a developer in downtown Manhattan.
Oh, my.
And it was a great residency program, great internship and residency program right in Lower Manhattan. We had the first coronary ambulance in the United States.
Yeah.
So part of that learning, and I ended up deciding to be a cardiologist. But, you know, the building was sold to a developer, and then about 6 years ago, I saw in the New York Times that the penthouse apartment, just the penthouse, went for $19 million.
Wow.
Okay, and I still remember being up there in the intensive care unit and the coronary care unit, sleeping overnight, you know, on the top of a bunk bed, you know, taking care of patients with acute MIs. That was it was just an amazing, and riding on the coronary ambulance, you know, when the police would call and say there's somebody who's having chest pain. I still remember in Herald Square, where Macy's and Gimbel's were, the day before Christmas, millions of people running around, and we got a call to get in there.
Wow.
And a truck driver was having severe chest pain, and we went out on the call. We picked this guy up. We brought him into the back of the ambulance, and we're checking him out. We get this knock on the back door, and this is in Herald Square, and we open the door, and it's a guy in his 50s or so, and he says to us, "Hey, I'm the head of the coronary care unit at Boston University Hospital. Do you need any help?" So as young interns, the two of us are saying, no, we can take care of this.
Right,
okay.
We got this.
But those are some of the experiences that I had, going through training, and then then I went into the Navy. I fortunately got assigned to Chelsea Naval Hospital, so I was teaching residents in the Navy, and I got partnered up with a physician who had just finished his cardiology fellowship at Emory in Atlanta, and so I was able to actually get some credits for cardiology when I went on to start my cardiology fellowship, just from being at that time at Chelsea Naval Hospital, and it closed while I was there because of the end of the Vietnam War, and also, as I remember it, Nixon decided to lower the military presence in Massachusetts, partly because we were the only state in the country that voted against Nixon, if you remember that. And then I went into practice on the North Shore. I got invited by one of my former Navy patients to stay on the North Shore and practice medicine there.
So you started off in solo practice.
I started out in solo practice, and so I did a lot of general internal medicine, having got my boards in medicine and cardiology, and then it became known, and I said, I can serve the community better by doing more cardiology. So my practice gradually morphed from medicine and cardiology into more cardiology. And it was solo private practice. I had to set up my own office and had some real struggles because, as you don't learn how to bill for
School of Hard Knocks.
Exactly, the real school of hard knocks. But it was a friendly community in Ipswich and Salem, and people welcomed me, and I had some new skills. Echocardiograms were relatively new then, and I became an expert in it. So I was able to use echoes to look non-invasively at the heart, and because I was still sort of young and used to the research, I actually ended up doing some clinical trials for some of the new cardiac medications. I was the first one in that area to have verapamil and nifedipine, and the first ACE inhibitors. So I did some of that research just as a solo practitioner.
Wow.
And it was a great experience learning how, drugs after their phase 3 and into their phase 4 trials. It was a terrific experience.
And in those days, the Medical Society acted as a great networking organization, particularly the local medical societies, because there you are in solo practice. You need to get to know the people that you refer to and that refer to you, and that was one mechanism of doing it.
Absolutely right. Without that peer help, I would not have succeeded. I mean, there's no question about it. It was the doctors in Essex South, and in the hospital, in Salem Hospital, and up in Ipswich, the small cable hospital. I became the chief of the emergency room. When I was in the Navy, I used to moonlight in emergency rooms around the North Shore and around eastern Massachusetts. In fact, I moonlighted in the emergency room in my hospital, in in Fall River, where I grew up, where my father was the chief of the medical staff. I ended up being one of the young guys in the Navy who used to staff the emergency room there, and we'd sometimes see 100 patients in a day.
Wow.
And it was so valuable to have a really good, well-trained, experienced corps of nurses.
Mm-hmm.
I still remember also at 2 o'clock in the morning one morning up in Ipswich in Cable, woman comes in and she's delivering her baby right in front of me. Now I had like 3 months of obstetrics when I was in training, and fortunately this nurse, she had delivered like 3,000 babies in her career, so she just walked me through everything. It was just an amazing experience, you know, and everything turned out okay. It was but that was the early days of solo practice. You did what you had to do. As the chief of the emergency room, I used to hire physicians from the General and from the Brigham and from Boston University, and they would moonlight in the emergency room, and I'd staff it. I still remember the blizzard of '78 when the roads were closed, and I'm driving up to staff the emergency room in my car, and, you know, there's supposed to no cars on the road, so I had people throwing snowballs at me thinking that I was violating the law.
Right.
Meanwhile, I'm going to staff the emergency room. It was,
right.
you know.